The recommendation by the American Academy of Pediatrics is within that first year, typically by about 12 to 13 months, the pediatrician, the baby sees a pediatric dentist for the first time. Typically by 1 year, the baby's going to have anywhere from about 4 to 8 teeth, depending on where he's at with his eruption schedule. So it just gives a good opportunity for a specialist to look at those teeth, to make sure that everything is coming in. I just took my son a couple months ago, and the whole appointment literally lasted less than 10 minutes. She was only, examined him for the length of it took her to sing the ABCs. He hated every minute of it, but she was able to look at his gum health, make sure that teeth were erupting appropriately, and tell me how many teeth she saw coming in. So he's right on track. But remember, it's not an exact science. As long as some teeth are coming in within that first year, there's not going to be a lot of concern. All right. The teeth aren't going to come in exactly straight. They're small baby teeth. He's going to lose them anyways. So parents can expect for there to be some gaps between the teeth. Doesn't necessarily mean that the child will need braces. But those start to come. Some babies really fight the teething. It causes them a lot of pain. And based on their temperament, they may have more protesting than other babies. Some babies, you just look at them and all of a sudden there's a new tooth. Okay. When babies start to crawl, can be a little bit dependent. Typically it has started around 9 months. Okay. Around 6 to 8 months, the baby should be able to sit on his own. And then the first locomotion movement usually happens from that baby being able to get into that, from that tummy time position. Usually starts as kind of an army crawl where he's like, scooting himself on his belly. Eventually that's going to progress to him being able to push himself up, which typically happens around 9 months. And we move from crawling, which is our belly on the ground, to creeping, which is where we're up. I don't really understand. I feel like they should be the opposite, but no one asked me when they gave definitions. So creeping, belly still on the ground, crawling, belly still on the ground, creeping, the kid is up on his hands and his knees. Okay. Typically happens around 9 months. No big physical changes at 10 months. We see some more teeth come around 11 months. Again, that's very dependent. And as long as we're seeing about 4 to 8 teeth within that first year, we're okay with that. Okay. And then 12 months, we see that birth weight triple, birth length should increase by about 50%. And then that anterior fontanelle is nearly closed. Typically around 11 to 12 months, this is where a child will start pulling himself up on furniture or whatever he can get his hands on, and he may start cruising, which means that he's holding on to furniture while he is trying to move about the room. Okay. All right, we'll move on to the toddler. So toddler starts at 1 year. We're now in chapter 32. So we're seeing some steady weight gain. Typically does start to slow down. It's not as rapid as it was in that first year. You can see the next big goal that we have as far as weight doesn't hit until 30 months. So about 2.5 years. And at that point, that birth weight should quadruple. So if he was 7 pounds at birth, by this point, by 30 months, he should be about 28 pounds. Okay. So I'm not going to keep going through these because I really want to get into our cardiac content. But just when you're looking at these questions, just reason them out. Okay. Those of you that have children, this may be a lot easier for you. Those of you that don't, you're not at a huge disadvantage. Just think about what makes sense. If the question says something about the child walking upstairs unassisted at 1 year, child's barely walking at that point. So that's not going to be something that really makes sense. All right. So when you're looking at these questions, just try to rationalize them with what makes sense on the physical capabilities. Okay. All right, so we're going to go ahead and jump into chapter 42, talking about our cardiovascular function. Anybody have any questions before we get started with the section?
Miss Bennett,
yes.
People waiting in the waiting room. They said they can't get in.
I don't have anybody in my waiting room.
Okay.
Thank you. They may be in the wrong classroom. I've admitted everybody that's in here. Okay, so now we are in chapter 42, so talking about our cardiovascular dysfunction. Some of this may be repeat from things that you've already heard when it comes to how we scan for things, how we're looking for disorders. That information is going to be very similar, so that might be a repeat for you. Okay. We're going to start this section with a case study. So Ryan is an 11-month-old who was born with Down syndrome. Ryan weighed 3.2 kilos or 7 pounds at birth, and a heart murmur was noted. Ryan was breastfed for 4 months. His mother states that at this time he became disinterested in breastfeeding, only nursing 5 minutes before falling asleep. Because he was not gaining weight appropriately, his mother began feeding rice cereal twice daily. At 4 months, Ryan was diagnosed with an atrial septal defect, which has been monitored since. Ryan sits unsupported, but does not stand or crawl. So based on the information that we just talked about, at 11 months, he's a little bit behind, but knowing that he wasn't eating very well, not a complete shock there, okay? He's also has Down syndrome, and that's going to delay some of those milestones as well. All right. According to his mother, he gets out of breath when attempting these tasks. Since 5 months of age, Ryan has been taking digoxin and furosemide daily. All right. So briefly, we mentioned yesterday that with cardiac dysfunction, I mean, same with the adult, there's going to be that element of fatigue. They are going to have periods of shortness of breath. If we are trying to get patients to feed, I mean, think about, this is always the great example that I try to give. If we have patients that have respiratory distress or respiratory distress related to cardiac dysfunction, think about the last time that you went running, all right? If you're an avid runner, this might not really work for you, but think about the last time you had to run up some stairs or something. By the time you got to that stair, up to the top of the stairs, if it was a couple flights, you might have been short of breath. If you had tried to take a big drink of a bottle of water, it wouldn't have been the easiest thing to do because your body would have been focused on trying to regulate your breathing. This is the same thing that happens to babies that are experiencing respiratory distress. The body is always going to pick the most important function, and in that moment, the regulation of breathing is going to be more important than trying to feed. So if the body has to make a choice, do I need to breathe effectively or should I eat? The body instinctively is going to try to breathe effectively, right? Which is why we start to see that disinterest in feeding, all right? So keep Ryan in mind as we go through these next couple of slides. We'll bring him back up in just a few minutes. All right, so when we're looking at cardiac defects, there's a couple of ways that we can classify them, okay? The first thing that we're going to look at is congenital. Yesterday, we defined the term congenital as being born with the condition, okay? This can be a structural, most likely it's a structural issue, all right? Can be infectious, related to something that was growing in that placenta or something that mom had going. But most likely when we are looking at babies born with cardiac dysfunction, it's related to an abnormal or physiologic issue, okay? So things like the PDA or the patent ductus arteriosus, VSD, coarctation, those things are most common, all right? If you don't know what those things mean yet, don't worry, we're gonna cover that in just a second, all right? The other way we look at it from this standpoint is acquired, which means the baby wasn't born with it, but somehow he developed that in either in utero or after he was born. Okay. Biggest acquired risk is infection. Example here would be endocarditis. So this can happen from a lot of different ways, and we'll get more into this in just a second. Again, can come from that placenta, can be something that mom had going, or can come from something that is just happening in the baby. We'll talk more about that in just a second. All right. When we're talking about autoimmune response, typically, and this is something that mom was experiencing that caused secondary effects in the baby. Best example of this is called Sjogren's syndrome. So this is an autoimmune disorder that happens in mom, and it can cause heart block in that baby, just related to the pathology there. Okay. So if we were taking care of a mom with Sjogren's syndrome, we would want to be on alert for that. Okay. There's plenty of things that we can do for this. And if we time it all right, we treat mom effectively, this is something that we can avoid. With environmental factors, we could be looking at tobacco, inhaled pollutants, pesticides. All of those can be factors for the environment. And then with familial tendencies, typically we're looking later in childhood. This isn't something we're going to see in those first couple of years. Can be secondary to obesity, hyperlipidemia, hypertension. That hypertension is an interesting one because when we talk about respiratory distress, I'll mention this again. But when we have our premature babies, they're born before their organs are completely developed. And depending on how early that is, it can cause a lot of secondary effects after that baby is born. We can stabilize him, and then our best hope is that we can grow him effectively, allow those organs to keep developing, hopefully without any complications. Okay. When we have babies who have advanced respiratory distress, because of all of the work that those lungs are doing, it often can cause something called pulmonary hypertension. All right. This is where the vasculature of the lungs actually gets over inflamed or has to work so hard to pump effectively or to breathe effectively for that child that it can lead into systemic hypertension. So oftentimes when we are seeing hypertension in our pediatric population, especially that young pediatric population, it is secondary to either severe respiratory distress or a cardiac issue that's already occurring. Okay. All right. So think back about Ryan. Some of the pediatric indicators wouldn't really tell us, is this a VSD? Is this a heart block? Wouldn't tell us any of that. Just general indications that something is not right and we need to look further. Okay. So that poor feeding, I've already explained this one, that if the body has to make a decision, it's going to be about those critical functions, right? Trying to regulate breathing. Feeding is not going to take a priority. All right. Tachypnea and tachycardia are both compensatory mechanisms, meaning it's the body's attempt to try to fix the issue. The heart beats faster to get more blood out. This can either be a volume issue or this can be related to there's not enough oxygen circulating through the blood. And the body is trying to fix that by pumping faster. Okay. Same situation with tachypnea. The body can understand that it is not breathing effectively. It's not doing enough with the gas exchange. So it tries to breathe faster so that it can breathe more of that carbon dioxide off and get more oxygen in. All right. Hypoxia comes from that lack of that lack of oxygen carrying capacity. Failure to thrive, poor weight gain, activity tolerance can stem from either one of the first three things that we've talked about. All right. Failure to thrive is something that happens when a baby is not getting enough nutrients. So if his body's having to make that choice, I need to breathe more than I need to eat, we're probably going to see either poor weight gain that may lead into failure to thrive. The hope is with those frequent checks within that first year, following that weight so closely, we're going to see that that baby is not growing effectively. And hopefully we will get to him before that failure to thrive point. All right. Failure to thrive means we're well beyond not just growing effectively. We talked about our growth chart yesterday. This baby is going to be low on that percentile, and he's really not going to have the energy to do anything. Yesterday, we also mentioned how healthy weight gain, healthy, eating effectively is tied into our neurologic development. These babies are not going to be meeting their milestones either, right? Because that's all related to having a healthy neurologic function. And if we're not eating effectively, that's not going to happen. Right. Positive prenatal history means there's something in mom's history. Either she has a cardiac function or dysfunction that we know has a genetic component, or she has something like Sjogren's that has those common complications with fetal cardiac dysfunction, or positive family history. If we have these factors in mom or the family history, we're going to look deeper from the beginning. Typically, if we're going, the family's going to their ultrasounds, we're not seeing any risk factors in mom's history, we don't do advanced testing when this baby is born. It's not until he shows us that he's having a problem, he has a murmur, or he's he's not being able to circulate well. We're not really going to go into any advanced testing if there's not really a reason to look for. That it would be invasive and just wouldn't really be a good way to use our resources. But if mom is showing us that there may be, in her history or in the family history, there may be more things that we want to look for, in the best case scenario, we diagnose it before it becomes a problem for that baby. Okay. All right. So how are we going to diagnose this? So we are, this is page 1225, 1226 in the 8th edition, and 1219, 1223 in the 7th edition. This chapter, these pages aren't too far off. So we're looking at tables 42.1 and 42.2 as far as your examination and some of the tests that we would do for these potential cardiac babies. So history and physical, we're going to do a full head to toe. We're going to look at all of the factors from our airway, breathing, circulation. We're going to listen to that heart. We're going to listen even closer for those potential murmurs. And if we can get those characteristics of, is it a S1 murmur, S2 murmur, is it a Gallup murmur, et cetera, it's going to help the healthcare team really make a diagnostic call on what cardiac dysfunction we may be leaning towards. All right. EKG is going to show us electrical impulses. The baby born that comes into the NICU is automatically put on EKG so we can have close monitoring. This is not something that the baby who had a healthy delivery, had no complications once he was born, we're not going to do unless there's a problem. All right. The next thing that we would do would be an echo. And this is just an ultrasound of the heart. It's not going to be invasive, but if we're looking at resource utilization, it's not something that we do for every baby unless that we know that there's a problem. Okay, so the ultrasound is going to show us the structures. It's also going to show us the blood flow. If you've ever seen an ultrasound, whether it was an echo on the heart or otherwise, one of the things that I find the most fascinating is when they turn on the Doppler and you can watch the blood flow. Blue is unoxygenated, red is oxygenated. I just find that absolutely fascinating watching it flow through. So they can watch that. If they're seeing what looks like purple blood, then they know that there's some defect wherever that purple blood is, because purple obviously means that blood is mixing. All right. You could also do, it's not something that would really help with cardiac, with telling what type of cardiac dysfunction we have, but we could also do a chest X-ray. And what that is going to tell us really is just the size of that heart. Cardiomegaly, so a large heart, is a complication that can happen when that heart is beating too hard. So if we're seeing cardiomegaly on that chest X-ray, it's going to tell us this dysfunction has been something that's been going on for a while. Okay, it's another compensatory mechanism for that body. The heart gets bigger because it's trying to pump more effectively. All right. The next thing that we can do is a cardiac catheterization. And as you see listed on your screen there's a couple different ways that we can use a cardiac cath. All right. We can use it as diagnostic. All right. We would inject some contrast into that bloodstream. And we're literally just watching the blood flow. We want to watch where this contrast goes in the pattern of that circulation. We can also measure oxygen in specific chambers of the heart, which would be able to tell us, is there a lot of mixing going on? Is there enough function in this heart that we can treat this with medicine, or do we need to do a full surgical repair? Okay. Can also be used as interventional. Some of the conditions that we're going to talk about in just a second can be treated with a cardiac cath. The big benefit here is that it's not open heart surgery. We're not having to really put that baby under. We're going to give some general, or not general anesthesia. We're going to give some local anesthesia, maybe something like a Versed that's going to calm that baby and have him to not fight the situation, but he wouldn't have to be fully put under, which means he wouldn't have to be intubated, so less invasive. Okay. Our transposition of the great vessels, severe PDA, ASD, VSD, they can all be treated. Again, if you don't know those acronyms, don't worry, we're going to cover them in just a second. The last way we can use a cardiac catheterization is through electrophysiology studies. What we would be examining here is dysrhythmias. Okay. So if we had a baby that kept going into SVT or supraventricular tachycardia, this goes beyond that point of, blood pulse of 200. We're looking at a pulse of like 230, 240, when that normal should cap off about 160. Okay. So if we have a baby that keeps going into that SVT, we could do a cardiac cath and really see why does this keep happening. We can also potentially treat those dysrhythmias that way as well. Okay. Important things to remember as far as your cardiac catheterization teaching. That site needs to be covered with an adhesive bandage that is going to be changed every 2 days. Site needs to be kept clean and dry, and you're going to observe for symptoms of infection. All right. So those are things that we see. Most of those are general signs of infection, right? Or post-op things that we do. Look for signs of infection, encourage rest and activity. We're going to, for the older child, we'll tell the parents to avoid any strenuous activities. Don't have to have any changes in the diet, where you can go right back to regular diet. May cause a little pain. So we're just going to go pretty basic there, acetaminophen. Depending on which reason we were using that cardiac catheterization is really going to determine how long that baby or child needs to stay, right? If it was diagnostic, we may be just looking at a couple of hours. If it was interventional, we may keep that child for a couple of days just to make sure that nothing happens after that. Okay. There's no complications. All right, so now we're going to, do we have a question?
Yes. How long for the dressing? Can you keep it on?
We're going to change that every 2 to 3 days. Yeah. Think of it, it's kind of like they're going into the artery, so it's like an arterial stick. So it's, as long as there's no signs of infection, it's going to heal pretty quickly. So probably would just have to change that bandage a couple of times. All right, so we'll start by talking about our congenital heart disease, our different types of congenital heart disease. Remember, this was, the baby is born with this, okay? All right, so just looking at some statistics, it's 5 to 8 per 1,000 live births. You don't have to remember that. It's really just the point here is to show you how frequently this happens, okay? It is a major cause of death in the first year of life after prematurity. There's so many complications that happen related to prematurity that can cause that death. Most often, if a baby dies within that first year related to prematurity, most likely it's related to some type of infection. Could be something that he had that was going on in the uterus, could be something that he developed when he was in the NICU, could be something at home, but their immune system stays depressed when babies are born premature for quite some time, and it's all dependent on how early they were born. So that can be a big cause. But after all of the effects of prematurity, next becomes cardiac dysfunction. Most common anomaly is a ventral septal defect, or a VSD. We'll talk about that in just a second. The other important point on here, remember our baby, our Ryan with trisomy 21 or Down syndrome, children with congenital heart disease often have another anomaly. Sometimes it's just a heart defect, and we go in and we fix that either with medication or surgery. But sometimes when we have a physiologic or things did not form correctly, it does encourage us to look for other things. Okay. When we have children with trisomies, either 21, 13, or 18, we have children with some of our complicated syndromes like Vactorel or Vader. It often means that we've got, or it also often includes cardiac dysfunction. Okay. So it can be something that just occurs. We just have a baby with a VSD and no other issues. But it also can be related or included in something else. All right. We'll talk more about some of those conditions, that Vactorel and Vader, nothing you need to know right now. Okay. Just a complicated genetic disorder. All right. You probably covered this in the first half of this lecture, but just to make sure, let's talk a little bit about fetal circulation. So big factors that we have with our fetal circulation, we've got our umbilical vein. Remember, we should have two arteries, one vein that connects that placenta to our baby. That allows that baby to get effective nutrients, to have good gas exchange. The lungs really aren't functioning at all at this point. They may be taking practice breaths, but they're not doing anything really a function. All that gas exchange comes through that placenta. Okay. So the umbilical vein carries that blood and nutritive materials through the placenta. Blood travels through the vena cava, through the ductus venosus. The foramen ovale shunts the blood from right atrium to left atrium. And that ductus arteriosus, I keep saying PDA. When we say PDA, we're saying patent ductus arteriosus. So this thing stays open after that baby is born. This connects the pulmonary artery to that descending aorta. So when our baby is born, he takes his first big breath. The hope is, or what happens naturally in most situations, is the pressure from that baby taking his first breath increases the pulmonary vascular resistance and the systemic vascular resistance, closes that foramen ovale, closes that ductus arteriosus, and we switch from fetal circulation into neonatal circulation. All right. That ductus venosus that we mentioned earlier, it just closes naturally. There's not a big process that happens. It just understands that it's not being used anymore and it closes. There's no real effects on our circulation. All right. So in this picture, we're looking at fetal circulation here versus neonatal circulation. Notice how pale pink this is here. What this is really saying is that the fetus survives on a very low level of oxygen. Those of you that have been able to see deliveries already this quarter or have in other experiences seen a baby be born, you know that regardless of the ethnicity, they come out kind of on the dusky side, right? Until they take that first breath, then they start to pink up. Okay. The reason that they come out on that dusky side, even if everything was going fine during that pregnancy and the delivery, is because they're living in an environment that's only about 60% oxygen. All right. So if I were to have a baby just be born and I immediately throw that pulse ox on him, it's going to be reading very low. He gets a full 10 minutes to come all the way up to above 90% in his normal pattern of switching from fetal circulation into neonatal circulation. The best thing that we can get for that baby to do is to cry. So you may see, or in old things, we see the doctor hitting that baby's bottom or tickling their foot. We don't really do that anymore. We do stimulate that baby to breathe if he's not doing it on his own. But the purpose is to really switch from that fetal circulation to that neonatal circulation. With fetal circulation, he was surviving on 60%, but he was connected to that placenta, and that placenta was doing all the work for him. That's not going to cut it anymore now that his heart is having to do all the circulation. We've got to get up into that 90s range. And he, like I said, he gets a couple minutes to do that. But we have to make sure that he's able to take over that ventilation on his own. When we're doing BLS on people older than the age of 1, our usual thought process is about that cardiac function, right? Ensuring that the heart is pumping effectively, right? With babies, especially newborns, it's really a problem of ventilation. Ventilation is usually the issue. So if we can get that baby to ventilate effectively within those first couple of minutes of life, everything should kind of cascade into its normal development, unless we have bigger issues, unless we have cardiac dysfunction, or there's some pathologic reason that that's not going to happen. So that first big cry is supposed to initiate all of these events that move us from fetal circulation into neonatal circulation. The premature infant is not going to, even if he comes out crying, there's not going to be enough pressure for him, even with his deepest cry, to switch this process over. So we're going to give him some PPV, or positive pressure ventilation, through a bag and mask that's going to force this to happen, okay? Because this is how we get into that normal circulation of what that baby should be able to do. All right, another way that we can classify our congenital defects is through acyanotic or cyanotic defects. This means that the disorder is either going to cause cyanosis in our cyanotic defects, or it is not going to cause cyanotic defects, cyanosis with our defect. All right. This is a very, very important slide for you to know. I know there's a lot of memorization, but this is something that you have to know. As we go through each of these disorders, it may help you understand why there's no cyanosis associated with these, and why there is cyanosis associated with these on this side here, okay? So if you look at page 1230, or 1230 in the 7th edition, 1224 in the new edition, there's a great figure or table, depending on which edition you're looking at, that goes through this. So good information to know, just really looking at which one is going to cause cyanosis. Like I said earlier, if there's no indicator for us to look further, we're not going to do any deep investigation as far as putting the baby on EKG or doing an echocardiac cath, any of those invasive procedures, if the baby doesn't give us a reason to, okay? So it typically is not until he starts showing symptoms, he gives us a murmur, he's showing periods of apnea where he's not breathing effectively, he's got labored breathing, he's tachypnic, etc., before we start really trying to figure out what's going on with him. We dig deeper, okay? So we're going to talk all of these disorders that you see listed, we're going to talk about all of them, all right? So starting with our acyanotic defects, so defects that do not cause cyanosis, we're going to start with our ASD. This is our atrial septal defect. This means that we have an opening between those two atria here, okay? So you can see some of the effects here. We've got increased pulmonary blood flow. We've got left to right shunting. Important things to remember about ASD: small defects can close on their own. Sometimes babies are born with ASDs and we have no knowledge of it. It just closes on its own because it didn't cause any effects. So a term baby who has enough compensatory capabilities of maybe breathing a little faster at times to ensure that his blood is circulating well enough, we may never know that he has an ASD because it spontaneously closed on its own. When we're seeing symptomatic ASDs of the small variety in babies that are, it's causing symptoms, we're seeing those effects. It's most likely because they're premature and they don't have the strength to fight off that. They can't increase their heart rate. They can't increase their respiratory rate to try to fix those issues, okay? So small defects may be completely asymptomatic. We may never know that this happens, or we may hear a murmur. That murmur may be the only thing that tells us that there's a problem. Okay. So what are we going to do with this? It really depends on how big that is. So the process of how this all unfolds, let's say we've got a term kid out on the floor, the nurse is doing his assessment, he hears a murmur. Okay, there's two things that nurse is going to do from this point. The first thing, and this comes from a standing protocol, so he doesn't have to have an order just yet. The first thing that he does is he is going to do what's called 4-point blood pressures, which means that each arm, each leg is going to get a blood pressure. What we're looking for is vast discrepancies between those upper extremities and lower extremities, because that would indicate a certain dysfunction. All right, we're going to talk about that one in just a second. It's called coarctation of the aorta. If we do those 4-point blood pressures, and they're all plus or minus within a couple points of each other, doesn't tell us that we don't have a problem. It just tells us that that coarctation is probably not it. After that nurse has that information, he's going to call the provider that's working with this baby, whether it's a nurse practitioner, a doctor, pediatrician, whatever it may be. He's going to call that pediatrician and give the information. At that point, because we have a murmur, regardless of what those blood pressures showed, we're going to do an echo. All right, this is non-invasive. Remember, this is just that ultrasound. That is going to tell us what our problem is. Okay. From that, we decide how much is this affecting our baby? Is it just that we have an uncomplicated murmur, meaning the baby's still breathing fine, he's still eating fine, he's maintaining his temperature, there's no big issues here? If that's the case, we're just going to watch it. All right. If we can avoid doing surgery, especially within that newborn period, that's always going to be preferred. Even for the term infant, he's not going to have a high enough immune response to really fight that surgical procedure, to fight all of those potential post-op complications. If we have to do it, we have to do it. But our best plan is to wait and let that baby grow. The heart gets bigger, so it's easier to work with, and he's going to have a better chance at fighting any potential infection. Okay. If it is a procedure, or if it is a defect that is large enough that we need to fix it, it's causing issues in our baby's cardiac function, then we can either do a patch repair, which literally is we put a material right here between. If it's a large defect, we may have to open that baby up. If it's a small defect, but big enough that it's causing effects, we can go back to that cardiac catheterization that we talked about. After we've inserted that cardiac cath, we can push the patch material up through the vessels and put it right in that area. Okay, baby's still going to need frequent monitoring here, but it would prevent us needing to open that baby up, which means that baby's going to heal much faster. The chances of complications are much lower. Okay. Very similar to this ASD is a VSD, but now our defect is between the ventricles. All right. So we still see that increased pulmonary blood flow. We still see that left to right shunting. Because we're seeing that left to right shunting, depending on the size, that's what makes these acyanotic, so not cyanotic defects, because there's enough mixing of the blood that what comes out of that aorta and into the body is oxygenated well enough that it's not going to cause cyanosis. Okay. So the same thought process as far as the defect. If it's a small defect, we may not have to do anything. If it's not causing problems, we may just watch. Large defects are going to need treatment. All right. We would still hear a murmur with this one, but rather than that diastolic that we hear with the ASD, we're going to hear a hollow systolic murmur, which means that it begins with that S1 and continues on with that S2. So it's a longer sounding murmur. Murmurs are really hard to one hear, but also to really determine, was that diastolic, was that holosystolic, was that S1, S2? What you really should focus on, especially when you have opportunities to listen to babies' hearts in this clinical experience is just, does it sound normal? Are you hearing extra sounds? Don't get yourself bogged down. Is it diastolic, systolic, etc. Just in your initial, listening, just listen. Does it sound normal? Does it give you that lub dub sound that you expect to hear? It's going to be obviously faster than the adult sound, but are you hearing any abnormal sounds? Okay. For our treatment here, it's very similar to that VSD, or sorry, to the ASD, and we're going to go with a patch if possible. Okay. We're going to talk about some other disorders in just a second that include VSD as part of their dysfunction, which means that when we go to the surgical approach, it's going to be multi-stepped. But if we just have an isolated VSD, the hope is that the patch is enough. Okay. Now we're going to move on to the PDA. So this is that patent ductus arteriosus. When we were talking about switching from fetal circulation to neonatal circulation, this is something that is supposed to close after the baby takes that first big breath because of that increase in vascular pressure and pulmonary pressure. Okay. This is a very common disorder, especially in that premature infant, because he doesn't have the ability to increase that pressure enough when he takes his breath to close that that ductus arteriosus. Okay. In our term infants, this is something that could stay open. We may hear a murmur in those first couple of days, but as that pulmonary vascular resistance and that systemic vascular resistance continues to rise, as that baby settles into neonatal circulation, it can spontaneously close as well. Okay. Typically within 72 hours is when if it's going to close on its own in the term infant, that's when we expect it to close. Okay. Again, we see that left to right shunting of blood. So we've got mixing of blood. Unless it is a large defect, a very large defect, we're not going to see any cyanosis. So it's technically classified as an acyanotic defect. But in our premature babies that have severe PDAs, the reason that we may see cyanosis is because the pressure gets to the point where the baby actually stops breathing. So we see apnea, and it's really that apnea that's causing cyanosis. So technically it's an acyanotic defect. So no cyanosis unless it's severe, but that severe is secondary to something else. Okay. So the symptoms in the baby are dependent on how large that defect is. So if it's a small defect, we may only hear that murmur with the hope that it's going to close on its own. So we would go through the process, same as I explained for that ASD. We do those 4-point blood pressures. For PDA, it's going to be the same. It's going to be very close. And then we do that echo. We're going to see this defect. And then based on the mixing of blood, we're going to decide how much this is going to affect that baby. Okay. So that murmur is very common. We see those wide shifts in SpO2 in our large defects. The first thing that we're going to try if we have to repair this is a medication. Those of you that have been pregnant, or it may have come up in the first half of this class, for a pregnant woman, she's not able to take ibuprofen. Okay. The reason that she cannot take ibuprofen is because it would prematurely close this ductus arteriosus. If this happens while the baby's still in utero, that ductus arteriosus closes, the baby's going to not get the oxygen that he needs from that placenta. Essentially, he's going to suffocate in the uterus. One dose of ibuprofen is not going to do that, but habitual use of ibuprofen would. Okay. So by that thought process, the way that we treat this once the baby is out is with a derivative of ibuprofen called indomethacin. Okay. We use that medicine. We have 2 opportunities to use it. It's a whole protocol. You don't need to know the protocol. Just know that indomethacin, a derivative of ibuprofen, is the first thing that we try to correct the PDA. If that does not work, now we have to try something more intense. All right. There is a non-surgical method that we can use for bigger babies. They don't, they can use that, that cardiac catheter. They have the coil inside, same with that patch, that they push that material up. And essentially, I mean, think about how coil works. They kind of just wrap it around this area here, this ductus arteriosus, and kind of cinch it closed. Okay, that works pretty well for bigger babies. All right. If we have small babies, so premature babies that have big defects where that indomethacin did not work, we're going to do a surgical procedure called a PDA ligation. Okay. That PDA ligation, we can do this at the bedside. The baby doesn't have to go to the OR. We're going to put him on his belly. We're going to make a small incision right by his scapula on that left side, and we're going to clip that in there. Okay. That is great for a small baby who's not big enough for the coil, who is not a good candidate for the catheterization. Okay. Again, we don't want to do these methods if we don't have to. All right. So we always prefer to take the wait and see method. If the baby's not that symptomatic, it's not causing him big effects, then we're going to try and see if he's going to grow out of it. If not, then we go through the next steps, right? The reason, the biggest reason that most babies, especially those premature babies, are going to need treatment for a PDA is because of those wide shifts in the SpO2. We see babies who, not having any issues, doing just fine. They're satting 95%, completely appropriate. All of a sudden they drop down to 60s. All right. And then we go and we check on them because the monitor is alerting and they're not breathing. All right. They're not breathing. They're not circulating. We can, if they're not breathing, we're going to give them some ventilations to help them. But if it's becoming an issue from that mixing of blood, it doesn't really matter how much oxygen we provide for them. It's not really going to change their issue until that heart is able to effectively mix their blood. So we could have been sitting at 21% FiO2 on our support. I could bump that kid all the way up to 100%, and it's not going to make a difference until his heart is able to more effectively move that. What we're looking at, and the reason that we have to treat babies that are having these issues and those wide shifts in the SpO2 is because it means that there's not enough oxygen circulating. So it's not about just the color that we're seeing. It means that the heart's not getting enough oxygen, the brain's not getting enough oxygen, the stomach's not getting enough oxygen. All of that means that we have potential complications that can arise from that. Okay. The biggest one is potential neurodegenerative brain dysfunction from that lack of oxygen. So if this is something that's happening frequently, we have to intervene. Okay. So we don't want to do surgery, but if we have to do surgery to prevent those complications, then we will. All right. The next thing we'll talk about is the coarctation of aorta. So what's happening in this defect, you can see where our aorta is right here. So aorta is going to send all of that oxygenated blood out to the body. This is tightened here. All right, we've got a narrowing here, which means the pressure that's going to be required to send that oxygenated blood out into the body is going to increase. All right, this means that the heart is going to have to beat harder. When we talked about doing those 4-point blood pressures, this is the condition. This is the only cardiac condition that would cause a change or a difference in those blood pressures. So what we see is a normal or slightly increased blood pressure and pulse in our upper extremities, but in our lower extremities, it's vastly decreased, usually by at least 10 points difference in our systolic in the lower legs. All right. So higher or relatively normal upper extremity pulses and blood pressure, lower pulses and blood pressure in those lower extremities. Those lower extremities can also feel cool to the touch because they're not being adequately circulated. These defects that we've talked about are all things that we can see on the ultrasound if they're big enough. But if we were to not have noticed that this baby had a coarctation or that there was no there wasn't enough prenatal history and not enough ultrasounds done that we would have been clued into this. Sometimes term babies can be okay within those first 72 hours. They can go out to the floor. We really don't know that there's a problem because in addition to their coarctation, they also have that PDA that we just talked about. And that PDA allows for enough mixing of the blood that that baby stays well enough circulated that we don't really see that there's a problem. Okay. There is a murmur that's associated with this one, but it tends to be an intermittent murmur that we don't hear every time we do that assessment. Okay. This baby is going to be at risk for hypertension because that increase in pressure that we take here can eventually become increase in systemic blood pressure. All right. So it can go from localized increase in that pressure to overall increase in blood pressure if we don't treat it. All right. So this is a disorder. We're not going to wait and see. We have to treat this one. The first medication that we're going to give, and this doesn't really treat the condition, it just helps facilitate the baby until we can get to the next step. The first medication we give is called prostaglandin E. Okay. The purpose of this medication is to keep that PDA open to allow for enough circulating, enough mixing of that blood circulating, so that baby is well enough oxygenated. Okay. That's the first thing that we're going to do. The next thing that we're going to do, if we can have a non-surgical approach, we're going to try a balloon angioplasty. Okay, can be done through that cardiac catheterization if possible. If it's a larger defect, we may have to open the baby. Okay, open up that heart. So same process, we would put that balloon here, and just like balloons in other places, it's just going to open up that narrowing so that we don't have to have that high level of pressure. Okay, if that is not an option, if the defect is too big, the next thing that we're going to do is surgery. All right, so we're going to do open heart, and then we're going to do a resection with end-to-end repair. That just means that we're going to go in here, we're going to cut open or shave off whatever that extra, that tissue is, and we're just going to widen this area. End-to-end repair is just whatever we separate, we reconnect. Okay. Any questions about this one? This one's a little more in depth. Any questions about how you would see or what you would notice in this baby?
So you said a murmur, right?
Yeah, so the murmur, but remember, most of the conditions we've talked about already are going to have murmurs. So that's not going to be the definitive thing. The definitive thing that tells you that this is coarctation is when you do those 4-point pulses and blood pressures, it's higher or relatively normal in the upper extremities and lower in the lower. That only happens with coarctation of the aorta. So if you're seeing kind of a case study scenario in your question, and it mentions that you have the difference in those blood pressures, you're going to know it's coarctation of the aorta. Okay.
Are there going to be graphic images of like hearts so that we have to identify
No.
the defects? No. Okay.
No, it's all through description.
Scenarios, and we have to identify what the defect is. Okay. Got it.
All right, some other defects for us to talk about. First, we have the pulmonic stenosis. Anytime we have stenosis, we're looking at a narrowing of the valve, okay? So what that is going to do is decrease the amount of blood that can flow through there or increase that pressure, okay? For both of these, what we're going to see is decreased cardiac output because it's not getting enough blood circulating. The way or what you would see on your assessment with decreased cardiac output, faint pulses. So rather than that 2+ normal pulse that you would expect to feel, it's going to be like a 1+. Okay. Also going to have hypotension because we don't have enough circulating volume. Tachycardia is going to be that compensatory mechanism trying to get more blood circulating. Poor feeding, we've already detailed the poor feeding happens because that baby is not, he has to make that decision, and breathing and circulating is going to take that bigger connection. In our older child, we may hear fatigue, exercise intolerance. They may actually complain of chest pain and dizziness as well. It's not that those things don't happen in our infant, they're just not able to express that. Okay. Best approach is going to be that non-surgical option with that balloon dilatation, just like we described with that coarctation. If we can do it with the cardiac catheterization, that's the least invasive. That's definitely the preferred method. If that's not an option, if the defect is so big or so great, we may have to do a valvotomy, which means we're going to open that heart and we're literally going to cut back on this narrowing and open that area up. Okay. All right. This next condition is a big one. Really put a star on this or whatever you do that says that this is really important information. Looking at this defect, so it's called a tetralogy of Fallot. You may hear this called a TET or see it TOF in your literature. Tetralogy means that we've got 4 specific conditions. So to call it this defect, all 4 of these following things have to happen. All right, so we have to have that VSD that we already talked about, that ventral septal defect. Then we have to have pulmonic stenosis. All right, we just talked about that one. Then we have an overriding aorta, which means that the aorta is directly over that VSD rather than over the left ventricle where it's supposed to be. So you can see that demonstrated here. And then we have right ventricular hypertrophy. That right ventricular hypertrophy is what happens. It's that compensatory mechanism of the heart trying to fix those first 3 issues that we talked about. So if you were to look at this on X-ray, this picture doesn't do a very good job of describing it or showing it. But this is often when we talk about a boot-shaped heart, this is the condition that we're talking about. So if we look at, let me find you. So we see this apex here is more pointed. Over here, it's almost rounded out. Okay, so we lose our apex here. All right. We're going to see acute cyanosis in birth. So we've moved into our cyanotic defects now. Acute cyanosis at birth because we have so much mixing of blood. It's not enough for there to be well enough circulated through the body. Okay. This can be progressive because it takes time sometimes for that neonatal circulation to kick in. So if we were doing okay with our fetal circulation, it may take time. And also this condition untreated is just going to get worse. We continue to see more and more mixing of that blood, which means that cyanosis is going to get worse. Another thing that happens, and this is something that only happens with tetralogy of Fallot, is something called a TET spell. Okay. What happens in a TET spell is this baby is crying and carrying on. He's real upset and he's nice and pink. Okay. Nice and pink, like a perfect little baby, because he's pushing all that pressure through. He's circulating the best he can. He's tachycardic. He's tachypnic. So all of that is working well. Okay. The minute that he goes to sleep or he starts to settle, we see him suddenly become cyanotic because he's not putting that same force through anymore. Okay. So when you're looking at these conditions, and this isn't just for cardiac, when you're looking at all of these conditions, try to find the one thing that is just specific to this disorder. So for this one, it's that TET spell. Okay. It doesn't happen with any other condition. With that coarctation, we said that is the difference between those blood pressures. So look for that big difference because it's going to help you distinguish from this disorder to another one. Okay. So what we're going to do for this, we're going to need to treat this. This is not a wait and see. So first thing we do is we close that VSD. Okay. We're going to have to enlarge this right ventricle because you can see this tissue here. This is where we're seeing that hypertrophy, but it's putting pressure on this ventricle here, meaning it's not going to be able to pump as effectively. So we're going to have to enlarge this. This is through bypass. Typically, this is a multi-step experience. It's not something that we correct everything We determine how soon we have to do surgery based on how symptomatic the child is. Okay. As I already covered, there is better prognosis with the older child because that heart is bigger, so it's easier to work with, but the body's also more capable of handling the demands that happen when we have surgery. So being able to fight off that infection, being able to stabilize after surgery. So if we can grow the child a little bit, then that is preferred. If not, if it's major symptomatic, then we have to do our step-by-step procedure. It's going to start with closing that VSD. All right. I saw in the chat, I think it was Ashley said that her child has TOF. Has he had any surgical repairs at this point?
Yes, ma'am. 3 days of life, she had her PDA stent input, and then she had her full repair at 6 months.
Okay. So that stent was put in to keep that PDA open.
Yes, ma'am.
So that's similar to what we talked about with that coarctation, allows for enough mixing of the blood. And then your baby had an opportunity to grow, get a little bit bigger. So she was more ready for surgery. How old is she now, if you don't mind me asking?
She will be 2 in May, but up until her full repair, we couldn't let her cry because of those TET spells, and that was pretty hard.
Yeah. How is she doing now?
Oh, she's growing very well. Up until 6 months, she couldn't really eat. She would get very fatigued, but then she started to get back on the growth track after her full repair. And then we'll require a pulmonary valve replacement around 10.
Okay. Well, I'm glad that she is doing well. All right. Do you guys need a break? Where are we at? That's something. We're about halfway through. Do you guys want to take a break?
Yes.
Okay, let's take a 10-minute break. We'll come back at 8:50 and keep going with our tricuspid atresia. This class goes way too fast.
Professor Bennett, I was just wondering, do you do any kind of like brief overview before any exams?
Yes, I do.
Oh.
I'm just hoping that we have time to cover it. I don't know why. I mean, the same amount of time that I had last quarter. I just feel like I'm rushing. But yes, I do have plans to do a content review before our exam. Hopefully we'll have time for it.
Yeah, it seems to be this first exam is going to have a lot of material in it.
Yeah.
Yeah.
All right, so let's jump in. We've got about 20 minutes left. We'll see how far we get with the rest of this cardiac information. So now we have tricuspid atresia. What happens with atresia is that the valve fails to completely develop, or it doesn't develop at all. What this means is there's no communication for tricuspid atresia. There's no communication between the right atrium and the right ventricle, which leads to that complete mixing of blood. Okay, signs and symptoms that we see here: cyanosis, tachycardia, dyspnea in that newborn means that it's going to be difficult for them to breathe. Because this is a congenital issue, if we don't diagnose it early, if it's not severe enough for us to see those symptoms early, if this becomes a chronic issue, we're going to see hypoxemia and clubbing. Okay, remember with clubbing, it is a long-term deoxygenated or low oxygen environment. No one is born with clubbing, okay, because in utero we have fetal circulation. It's all done through that placenta. It's not until we come out that we switch to neonatal circulation. So if your question says the newborn with clubbing, just know that's not a thing. That cannot happen. Clubbing is long-term deoxygenated. Okay, so we see that in older children, not our babies, right? Treatment here, it typically is going to require a few surgical repairs. We're going to start with that palliative shunt, okay, to keep that PDA opened so that there's enough mixing of blood that we have decent circulation, okay? Then we move on to the transposition of great vessels. So this is TGA, may also see it TGV, both are still accepted. Much like that coarctation, for this baby to be okay enough to survive long enough for surgery, we have to have that PDA. There has to be enough mixing of blood or a septal defect, an ASD or VSD. Otherwise, everything that comes out is going to be completely unoxygenated, and it's going to be fatal. Okay. So you can see what happens here, talking about our transposition of great arteries. So the aorta and the pulmonary artery have switched places, which means what's going into the body from the aorta is unoxygenated blood, and what's going into the artery is oxygenated blood. So completely backwards, which means that, which means that what's going into the body is not going to be oxygenated enough unless that PDA or unless one of those septal defects is intact. Okay. Signs and symptoms, we're going to see cyanosis with this baby. We're going to see signs of heart failure. Cardiomegaly is going to happen very shortly after birth because that tissue is working so hard. Medications that we're going to start with here, that prostaglandin E. So we use that with our coarctation to keep that PDA open. We're going to do the same thing here. Even if a PDA has had the opportunity to close, if we start that prostaglandin very soon after birth, we can pop it back open, okay? That way, if there wasn't already a PDA, there wasn't a septal defect, we have a chance to stabilize this baby before we can take him for treatment, all right? If possible, we want to go with that cardiac cath treatment. We can do that balloon atrial septostomy to open up that tissue. If not, we may have to do the atrial switch. That is the preferred method. But for it to be a surgical option, we have to be able to stabilize that baby long enough for them to grow. The hope is to get them to 6 months. If we're trying that balloon atrial septostomy with cardiac cath, it means that our disorder is very intense and we need an immediate correction, okay? So in that atrial switch, we literally just switch those. We surgically fix these so that we've got the aorta that's bringing in our oxygenated blood, and we've got our pulmonary artery that's going back with the deoxygenated blood into the lungs. So we try to switch those back, okay? All right. The next condition we're going to talk about is called hypoplastic left heart syndrome. Now, treatment for this has gotten much better. When I first started in the NICU, this was darn near a death sentence. Okay. You can see our left ventricle here is not developed at all. All right. This means that there's not going to be very much blood that can go through there, which means that it's going to not be very effective coming out into the rest of the body. Okay. For this to be a survivable event long enough for surgical repair, is we have to have an ASD or a PFO, now that patent foramen ovale, which would allow for enough mixing of blood. All right. We're going to see mild cyanosis until heart failure sets in or until that PDA closes. Then our cyanosis is going to get severe. All right. That is going to lead into our decreased cardiac output which, left untreated means that we're going to have cardiovascular collapse. If we get to the point of cardiovascular collapse, it's going to be really hard to pull that back. All right. So our best case is to know before this baby is born that this is the situation and be ready for immediate treatment. Okay. When I've dealt with this in the OR, back when I was still in clinical practice, we had prostaglandin with us. We were ready to intubate that baby. We were ready to do all, major things to stabilize that baby from the minute he was born to give him the best chance. When I first started in the NICU, I saw many babies pass from this. Okay. So it used to have a very, very low prognosis and a high mortality rate. But now that we can diagnose this much earlier, we see this in utero. In certain areas, this is actually something that can be repaired while that baby is still in the uterus. I think I looked it up once. I think there's a center in Houston that does it. I think that's the only one in Texas. It's very, very advanced fetal surgeons that can do this. But I mean, if we're fixing it in uterus, that means by the time that baby comes out, he's able to switch into neonatal circulation and not have a major issue, right? If it's not done in the uterus, if we're not near a center that can do that, or the baby's not a candidate or whatever, it would require multiple surgeries to fix after. Okay. If it's that bad, if it's that severe where we barely have any ventricle, there's nothing really to repair, the baby may need a heart transplant. And just to put some perspective on it, any type of organ transplant within that first year is very difficult. One, there's not a lot of donors. Most of the babies that die within that first year are not good candidates for organ donation. And then the organ has to be so small to fit into that tiny little area. So if we're waiting for a heart transplant, the prognosis for that is going to be very low. All right, the next thing that we're going to cover is congestive heart failure. There's several important things that you want to keep in mind. When we're looking at congestive heart failure, there's two ways that we can really talk about this, right? We've got right-sided, or we've got systemic symptoms. In right-sided heart failure, the right ventricle is unable to pump effectively into the right atrium. This leads to that increased pressure in that right atrium, which is what causes that systemic venous circulation. These babies are going to have hepatosplenomegaly, so you'd be able to fill that on your assessment, and occasional edema. Okay. If we're looking at left-sided heart failure, we're going to see our lung symptoms. So now it's the left ventricle is unable to pump into systemic circulation. That results in increased pressure in our left atrium and in our pulmonary veins. We're going to hear congestion in our lungs. This is going to lead to increased pulmonary pressure and pulmonary edema. So we've got junky lungs, we've got tachypnea, all of those signs of shortness of breath. Okay. Any questions about this? Really important that you get those differences. Got it? Okay. All right. So looking at it, heart failure from a general standpoint, we see tachycardia and tachypnea at rest. Remember, those are our compensatory mechanisms. We see dyspnea, difficulty breathing, retractions that show that body is having difficulty breathing. Activity intolerance is typically manifested as poor feeding in our infants. could be fatigue or exercise intolerance if we're older. We see that weight gain from that fluid, hepatomegaly and cardiomegaly, increased pulmonary flow, blood flow, especially if we've got left-sided. And then if we were to do an EKG, it would show that ventricular hypertrophy. So there's three major effects here. Okay, so we've got impaired myocardial function. That's where our tachycardia, our diaphoresis, our decreased urinary output comes from. We've got pulmonary congestion. That's our tachypnea, our dyspnea, retractions, flaring, nasal flaring. We'll talk more about that next week. Exercise intolerance, that orthopnea, meaning it's difficult to breathe lying down. Cough, cyanosis can all be part of that pulmonary congestion. And then the third part, so this is our right-sided failure, is that systemic venous congestion, right? So we may see in our older children that JVD, that jugular vein neck distension, weight gain from that edema, hepatomegaly, peripheral edema is very common, especially periorbital, may have ascites, so that edema in the abdomen, okay? All right, so our treatment goals for heart failure, first and foremost, we want to improve our cardiac function, all right? We may use digoxin. Remember, this is a high alert medication. Just like you had to check that apical pulse in your adult before giving digoxin, we're going to check that in our patient as well. All right, so write this down. 90 to 110 in our infants and young children, it's okay to give. Over 70 beats per minute in our older children, okay to give. Okay, outside those parameters, we're not going to give it. All right, remember, it's going to bring our heart rate down. So if our heart rate is already too low, we're not going to give our digoxin. All right. The other thing that we have to look for is toxicity. Dig toxicity manifests in nausea, vomiting, anorexia, bradycardia, and if it's very severe, dysrhythmias. Okay. Typically that nausea and vomiting is your first sign. Those other signs are more late symptoms. Okay, so we have to make sure that if we're giving digoxin, that we're monitoring those lab levels to make sure that we stay within that window. All right, when we're looking at that left side failure, especially because we see that pulmonary congestion, or we're seeing a lot of edema from that right side failure, we may give some diuretics. Okay, Lasix, Diuryl, Aldactone are very common medications that we may give. Remember, when we're giving diuretics, if we're giving that Lasix, what are we monitoring for? Is Lasix potassium sparing or potassium wasting?
Hypokalemia.
Yeah, we're looking for hypokalemia. Very good. Which may show us those dysrhythmias, right? So we monitor our electrolytes, especially our potassium. We also follow our INO. Because we're giving diuretics to pull fluid off, we need to follow our weight gain. We want to make sure that our treatment is effective. So we're going to start with that baseline, and hopefully as we're giving those diuretics, it is going to bring that weight down. Okay, decreasing cardiac demands means that we're going to minimize our metabolic demands. This means that we keep our baby in a neutral thermal environment. We want to treat any issues such as respiratory, fluid imbalances, blood sugar. All of that is going to increase the metabolic demand, which means it's going to put more stress on the heart. So any active problems, we want to fix that. And if there is tissue oxygenation issues, then we're going to fix that as well. We may give oxygen, we may not, depending on the cause of our cardiac failure, is really going to tell us where we want that pulse ox to sit. And that's going to determine, do we need that oxygen or do we not? But that's typically case by case basis. Okay, we do want to remember, we'll cover this next week, that oxygen is considered a drug. So we do have to make sure that we're using it by the order. But we'll get more into that next week. All right, so let's go back to our case study. So Ryan, he's brought to the cardiologist by his parents because he has been lethargic, has diarrhea for 24 hours. His assessment is as follows. So he's 7 kilos now, 97.9 on temperature, heart rate's 80, respiratory rate is 35. Potassium's 2.9, digoxin is 2.5. Remember, he's 11 months old. So weight's okay. He was, I want to say he was 3.5 kilos, so no big issues with weight. Are you seeing any other big red flags here based on what you have? Based on your information? What's our normal potassium supposed to be?
3.5 to
Yeah.
5.1, so
5.2.
it's really low.
Yeah, so that's low. So that's a big problem. And you may not know this, but the digoxin is very high. Dig level and therapeutic volume should be 0.4 to 0.9. So the fact that it is 2.5, we definitely have some dig toxicity going on. But that potassium is also a big issue. So we need to get those fixed. All right, so now we're going to see how far we get in our acquired cardiac defects. So first we'll talk about infective endocarditis. So the pathophysiology here is that there's a bacteremia. So there's bacteria in the blood that gets into the heart and it causes vegetations. Vegetations are growth that happen. Typically, it happens at those valve areas. So two big complications here. One, it could become an embolus, dislodge, and now it's circulating through the blood, causing potential deep vein thrombosis, pulmonary embolism, et cetera, or aneurysm. And then the other factor is valve damage, the other potential complication there. Okay, so our best guess here is or our best treatment option here is to diagnose this early. For our patients with high risk, we're going to preventatively treat them with antibiotics. Our signs and symptoms, and that's the hardest part of treating, of diagnosing this early, is that we don't, it starts out very minor, right? We've got an unexplained low-grade and intermittent fever, anorexia, malaise, where we generally just don't feel well, may see some weight loss. Doesn't tend to be obvious to the clinician until we start to see some extra cardiac emboli formations. Okay, here we're going to see this in petechiae. Maybe we see some splinter hemorrhages in our nails. By this point, we're already to the point of vegetation settling in. Okay, if it hasn't been picked up by this point, this will lead to heart failure. All right, so we'll see dyspnea, new or changes in an existing murmur may happen, continuing to be untreated. We could get to a point of complete cardiac failure. All right. Hopefully it's been diagnosed before then. Patient's going to need long-term high-dose antibiotics. So since it's long-term, we're probably looking at a central line. Doesn't mean that the patient has to stay in the hospital for that entire time, but it does mean that they're going to need those long-term antibiotics. Typically, it's 10 to 14 days, depending on what bacteria is going. Okay. So looking at those complications, the patient's going to need to follow up with cardiology, just to follow those valves. If there was damage, the child may need a valvotomy, meaning we're going to have to go in and replace that valve. Okay. The next condition is rheumatic fever. This happens secondary to a strep infection. Okay. On the next slide, we've got a great picture here of what happens. So we've got that chorea, that involuntary movement, carditis. We've got inflammation of the heart. This erythema magnetum, that's a very hard word to say. It's the red lesions. So that's a pretty definitive for this condition. Okay. So remember, looking at those big red flag symptoms, this is your one here, that red skin infection. Okay. So this is going to affect our joints. It's going to affect the skin, the brain, and the heart. We diagnose this with that ASO titer. All right. So that's going to tell us that there was strep circulating in this blood. Typically, when we're getting the history from this family, they're going to say that the child recently had a strep infection. All right. Management over here, you can see antibiotics, bed rest, quiet activity. And now because of this experience with rheumatic fever, we talk about prophylactic antibiotic therapy to prevent infective carditis. This child is now a candidate for that. Okay. All right, I think the Kawasaki disease, yeah, we're going to cover Kawasaki disease and then we'll go. Okay, last disorder, this is an acute systemic vasculitis. Don't really know what causes this. It is not transmitted from person to person. It's not really related to any type of infection. It is diagnosed based on the clinical findings. So we can see that here. Looking at your big red flag symptoms, it's this strawberry tongue. Okay, so if you're looking at case scenarios on your exam and you see strawberry tongue, it's this. This only happens with Kawasaki disease. Okay, so you can see other things. These superficial skin layers desquaminate, meaning they peel off. The other big thing is this high fever. Okay, over 102.1. All right, so once we've diagnosed it, we're going to give high dose of IVIG, which is intravenous immunoglobulin. We want to give that within the first 7 days of the illness, because that gives us our best chance at preventing complications. And then we give high dose aspirin therapy. All right. Symptomatic treatment means that if there is a fever, we treat it. The new thought process with treating fevers these days is not to treat them until the baby or the child becomes miserable, because that fever is your body's way of responding to try to fight that infection. Okay. Heart failure can be a complication, so we do want to watch for that. Okay. So big thing that you're watching for, that strawberry tongue, that's your big red flag. And then we want to remind parents that high fever is common during this phase. Okay. So expect it to be 103. Typically, as long as it stays below 105, which I know is very high, not going to be too concerned. If we get to 104, that's a great time for Tylenol. Child is probably going to be protesting at this point. Okay. I know we went a little bit over, but I did want to get through this section. Anybody have any questions before I let you go?
No questions.
Okay, were y'all able to find where I posted the recording from yesterday at the very, very bottom of your modules? It's okay if you haven't looked for it, but that's where it'll be. As soon as this one is done, I'll post it as well. Okay.
Yeah, I saw it there.
Yes, was able to find it.
Okay, great. All right, you guys have a great week and I will see y'all on Monday.
Thank you.
Bye.